Good morning, everyone. Today we have Jana Lipkova from Harvard Medical School, Brighton and Women's Hospital, giving a presentation about AI assessment of cardiac allografts rejections.
Hi there. Can I start, or shall we wait a bit more?
No. You can start, or if you want to say something more about yourself, or start.
Okay, now I will start. I will just say that I don't see you when I'm in the presenter mode. So if you have any question, just shout anytime and I will pause and we continue. And keep asking on the fly so you don't have to hold your question like for 40 minutes or something. Okay, so I will be presenting the work about heart transplants. So first, a little bit of background. You probably know that heart failure is a leading cause of hospitalization in US, in worldwide, also in Europe. And in the world, we have around 26 million cases of heart failure every year. And when you have patients with end stage of heart failure, usually the heart transplant is often the only viable solution for these patients. And yearly, there are performed around 5,000 heart transplants. So like if you compare it in the terms of data, we have significantly less data compared to cancer or other studies. But what is the process behind? So once the heart is transplanted, the biggest risk is the rejection. And because the body can consider the new organ as a foreign object and try to suppress it or reject it. And the rejection is not issue only after transplantation, but it can happen anytime. Like you can have a patients that get rejection after 15, 20 years after transplantation. So to prevent the rejections, patients are treated with immunosuppressive medications, which are usually tailored for patient-specific conditions. But despite the medication, heart rejection is still one of the main cause of mortality, and it's also the most critical conditions for the patients with heart transplant, and it affects approximately 40% of our recipients. Now, once there is a rejection, it can be suppressed with the medication, so it's not end stage, but depending on the rejection type and the extent of the rejection, the medication can be tuned, and the rejection is going to be suppressed, so it's going to be like a repeated cycle. You change the medication and you observe the patient for more rejections. The issue is that the early stages of rejections are asymptomatic, and therefore the patients, they have to undergo regular surveillance biopsies to monitor their state. And the cardiac biopsies, I didn't even know you can biopsy heart, but it's really cool. You can inject needles through the veins in the neck directly to the heart, where you extract small piece of tissue. This tissue is then embedded in the paraffin block, which you can see at the bottom. The block is cut to very thin slices, which are attached to glass slide, and you end up with these glass histology tissue slides. Maybe I'm also coming from radiology background, so I didn't know all this stuff, but it's interesting. So the tissue itself, of course, doesn't have any color. So if you would look at the raw tissue under microscope, it looks something like this. But for the analysis, we stain the tissue with different stains. And there are many different types of stains, but the most common is also called H&E stain. It's using two stains, hematoxylin and eosin stain. So here you can see the corresponding stain tissue. And hematoxylin, it's a blue-purplish stain, which basically stains cell nuclei. So all these blue-purple dots you see are the cell nuclei. And eosin, it stains extracellular matrix and cytoplasm in pinky. So now we know what these images mean. Okay, so having these the pathology images, how these glass slides are then examined to make the patient diagnosis. So the gold standard is manual assessment of these H&E stain biopsies. And the assessment involves detection of the rejection, specifying the rejection type and the rejection grade. The grade basically represents severity of the rejection, and it varies from 1 to 3. And there are two types of rejection. We can have acute cellular rejection or antibody-mediated rejection. Moreover, this rejection, they can coexist. So you can have a patient that have both acute cellular and also antibody-mediated rejection. And we also have like benign mimickers of rejection, such as Quilty B lesion, which is in a sense benign condition because it doesn't require changes in medication, but it's still like abnormal finding. But the important thing is that it looks like a rejection, but it's not rejections. And because of this, it's also reported in the patient sign-out sheet. And as we mentioned before, it's the type and the grade of the rejection which is used to determine the patient treatment with immunosuppressive medication. As I mentioned before, I'm not pathologist, so always when I work with a new disease model, I'm trying to understand what I'm looking at, what these images mean. So here is like a crash course on the cardiac biopsies. What you can see in the first column is like how the normal cardiac tissue look. So heart is in principle muscle. So you have this very typical muscle structure. You have uniform architecture, very smooth, regular morphology of the tissue. Now, in the case of acute cellular rejection, they are characterized by the presence of lymphocytes infiltrates inside the muscle tissue. And these infiltrates usually have uniform structure and they comprise of T cells. So all these purple blobs that you see, these are the lymphocytes between the muscle tissue, and this is the signs of acute cellular rejection. On the other hand, antibody-mediated rejection is characterized by increased extracellular space caused by edema. So this is what the red arrow is showing. You can see this like abnormal space or swelling between the tissue. Or antibody-mediated rejection can also be characterized by changes in capillary. So that's what the green arrow is showing. There's like artificially squeezed capillary. And these are the Quilty B lesions, which are also characterized by infiltrated lymphocytes and other like B cells or macrophages, but basically again have this blob of purple infiltrates, which visually look very similar as acute cellular rejection, and they're often confused. So this is how the rejections look like. In the terms of grade, this is kind of tricky. So I said that the grade vary from 1 to 3. And for instance, in the case of cellular rejection, the grade 1 is defined by the presence of one focal injury. So there is, if you can see my blob, there is this one blob of purple infiltrates. Grade 2 is defined with 2 and more injuries, and grade 3 is defined with multiple injuries and several other abnormal findings like hemorrhage. And basically the grade 3, you can see there are a lot of purple stuff and a lot of things went wrong. And this is very similar for the antibody-mediated rejection. Grade 1 is specified by the presence of one of antibody-mediated rejection morphology. Grade 2 require multiple signs of the rejections and so on. The problem is that the grades, it's even is like you have a number of injuries. It's very qualitative. Like for instance here, what do you say? This is one big diffusive injury, or there are two small injuries. So it's kind of very subjective. And the rules, also the official guidelines, are mainly qualitative, and it's not always clear where to draw the line to make the decision. So because of this, assessment of rejection of cardiac biopsies is not so straightforward. For instance, if you compare it with the detection of a cancer from the histology point, cancer is determined by the presence or absence of specific like neoplastic morphology, either there is cancer or not, and usually they look similar. In the case of cardiac rejection, the disease manifestation itself represents by it can represent very differently depending on the type of the rejection, grade of the rejection, plus you can have these multiple you can have these benign mimickers of rejections, and everything can coexist. You can have Quilty B lesion, acute cell rejection, antibody-mediated rejection all at the same time. And the assessment of the rejection is more or less qualitative, so it leaves a lot of space for like subjective interpretation, and there is really large inter-rater variability. There was actually a reader study that shows that less than 71% of cardiac experts agree if the patient is rejecting heart or not, and less than 28% agree on the grade of the rejection. So as you can imagine, any misinterpretation of the diagnosis is gonna lead to the either under or over treatment of the patient with immunosuppressive medication. It can cause unnecessary follow-up biopsies and overall contribute to the worst outcome. So the motivation, this very long motivation, was we would like to develop a tool that allows objective and automated assessment of these heart biopsies. So to address this problem, we propose cardiac rejection assessment neural estimator, or CRANE in short. CRANE take as an input agent stain whole slide image and simultaneously. If you have questions, just shout out because I don't see you. Sorry.
No, we are following. We're interested.
Okay. So the model takes as an input the H&E10 whole slide biopsy image, and it simultaneously identifies all the major diagnostic tasks. So basically for each slide, it says if there is cellular rejection or not, if there is antibody-mediated rejection or not, or if there is a Quilty lesion or not. And for each rejection, it also estimates the grade of the rejection. So from the implementation point, CRANE is basically a multitask model because it learns all three tasks simultaneously, and it's also a weakly supervised model because we don't use any, we use only patient diagnosis as only label. We don't do any image segmentation or feature extraction. So patient label is referred as a weak label because we don't have any annotation. And also, since we don't have annotation, it's kind of easy to apply the model to large data set, and the pre-processing cost is lower. So here at the bottom, you can see the architecture of the model, and I will go through it in more detail. Before I do just last detour about the histopathology, and it's like once we have this glass slide with the tissue, we have to digitalize it. So you can either put the glass slide under the microscope and take the image, or you can have a scanner that allows you to scan the whole slide. Now, the thing is, with the microscopy images or with all this tissue, you can see different morphology at the different magnification levels. So the whole slide scanner actually scanned the tissue at different magnification and glue it together. It's very similar. Basically, it's the same pattern as principle as the Google Maps page. You can, if you look at some landscape from the low magnification, you can see different things, and you can like zoom and you can see very different structures. But because of this, these images are huge. Like single histopathology image has. Did you want? Okay.
You like froze, but.
Oh, okay.
No, but it's okay.
I'm sorry. Okay. So what I was trying to say is that these images are like Google Maps. So you can basically zoom and you can see different morphology at different magnification. But because of this, the images are huge. So one whole slide image has over 1 billion pixels. If you compare it with the radiology images, if you have full body scan at 1 millimeter resolution, you can have, I don't know, a few million pixels, but we have 1 billion pixel, more than 1 billion pixels per the whole slide. So just interesting comparison is only 100 of these images have more pixels than the whole ImageNet. So they are huge. And because of this, we cannot like compute or run the simulation on the whole slide images. So what we do in the terms of preprocessing, we first segment the tissue inside a glass slide because we don't care about the background. And then we divide the image in small patches, as you can see here. And having the patches, okay, so let's say we had the whole slide image, we divide it in k small patches, and then the patches are usually 256 times 256, plus we have 3 RGB channels. But the images are, these patches are still really large to run the model, especially we have thousands of these patches, so it's still quite heavy for computations. So instead, we would like to reduce the size of the patches, and we want to compute embedding. So it's like a low-dimensional representation of these patches. And what we do, we use ResNet 50, which was pre-trained on ImageNet, and each image patch is embedded to low-dimensional feature vector of size 1024. So rather than having these images, which are huge computationally, each patch is now represented by a vector of 1,000 entries. And because the ResNet 50 was trained on ImageNet, we also include 3 fully connected layers afterwards just to refine the features to be a bit more histology specific. So at this point, we have like a lot of embeddings. We have a low dimensional vector. So we have patch level embeddings, but the thing is, we don't have patch level labels. We just know if the patient has rejection or not. We don't know which patch correspond to each diagnosis. So we would like to somehow aggregate information from these patches to form like a patient level representation rather than just having patch level representation. And to do so, we use so-called attention-based learning. So now for simplicity, assume we have just one task. Let's say we just want to predict if there is cellular rejection or not. And the attention-based learning is basically a process where we teach the model to score each patch based on how informative that patch is for making the specific model prediction. So here at the figure, you can see like several patches and corresponding like attention score that was assigned to this color blue and red. It's like how important each patch is for making diagnosis. And A is in the equation is the attention score, which corresponds for each patch for each task. So once we have the patch level attention scores, we then compute weighted average of the embeddings where we weight. So we basically weight here HK are the embeddings of each patch, and we weight it with the attention score that correspond to each patch, and we compute the weighted average together, and we use this to end up like a slide level embeddings. So now we have a slide level embeddings which can be used for the slide level predictions and combined with the slide level label. So this is in the case if we have only one task. If we have 3 tasks, we're gonna learn one attention for each task. So for each patch, we compute 3 different attention scores, one per each task. And as you can see here, we have 3 networks that we learn, and they are divided in. So this is the attention model, and we divide it in I hope you can see my mouse. So we have three attention components, and there are two parts. Like in the first layer, we learn jointly the attention score for all tasks, and in the second layer, we have one network specific for each task. And that idea is at first we just use the network to learn a typical tissue, and then in the second layer, we learn tissue specific for each task. So like the first layer is learned jointly for all tasks, and then we have one specific layer per task. After this, we basically end up with one embedding vector for each task, and which is then used as an input for the final classifier. And we just predict if there is a cellular rejection, antibody-mediated rejection, or Quilty lesion. And for the grade, we use the same approach, but we just have single task because we try to predict if there is low versus high grade rejection. The reason is that the grade 3 is very rare, and we had like 3 cases in the last 20 years. So we put it together with grade 2. So that's the architecture. The interesting part is once you have these attention scores, you can map them back to the original histology image, and you can get these colorful attention heat maps, which tells you which part of the tissue the model considered to be most predictive for making the diagnosis, and you can use it for validation purposes. So that's the model. In the terms of study design, we collected around 7,000 whole slide images from 3 different centers, from US, Turkey, and from Switzerland. And these data sets were designed on a purpose to reflect the large variability that exists in histopathology data. So we have different population, each center used different scanner, each biopsy or each center has different biopsy protocol. For instance, in Turkey, they stain the slides manually, while in the US and in Switzerland, they have automated staining, which these are all factors that results in really large variation in the data and can affect the model performance. Just to know. So we trained the model on the data from US only, and then we want to see how the model generalized to the test sets from the US and to the 2 external cohorts from Switzerland and Turkey that were not used in the training. But we don't use any domain adaptation. We want to develop some model that's robust to all these changes. So this is just like visualization where you can see different color composition and like visually can appreciate that the data are very different because it's coming from different scanners. And
Swiss are very saturated.
So the reason is they use 3D high-spec scanner. It's a different scanner, and for some reason, it always makes the images look more purple than they are. What is interesting is like in the Turkey, the color like really vary. Like in Switzerland, they are saturated, they're purple, but kind of uniformly. But in Turkey, it's like all around the place. But it's interesting. Also in Turkey, sometimes, since they stain it manually, sometimes they forget one stain. It's very painful. But I was like very...
Did you do, because of this, did you do any kind of normalization, or you just literally train as they are?
We train only on the data from US, and then we apply it to the external cohort. We try later some normalization and other strategies, and I can show you the results and I can discuss it in a second. But so we didn't do any domain adaptation. We just really train on data from US and we apply to the other cohorts. And what we see here is in the first row, you can see AUC scores for specific task, and the second row is accuracy, wherein the blue is performance on the US cohort and orange and green is performance on the external cohort. And like we can see for US cohort, the performance is around 0.96 for rejection detection and kind of similar for the other task. But you can visually see there is a drop in performance when you go to external cohorts. Now, since the model has very comparable performance on 2 very different cohorts, it implies that it's able to generalize and is learning relevant features, or it's able to generalize to new data. But of course, there is a drop in performance. And now this is to your questions, like how you can handle it. And we try very different strategies. So first, I want to say that the performance on the external cohorts, it's still comparable to the human readers. So it's still like very high, and I'll show that later. But of course, if you would like to apply these models in like any clinical settings, you want to minimize this drop in performance. And we try, I try a lot of stuff. I try like color normalization, stain normalization. I try like some generative approaches to transfer like appearance of images from one cohort to another one. I try adversarial attacks. The thing is, some of these methods work, but I usually work on one cohort, but not on the other. So I didn't find anything that was like robust enough across all the cohorts, which is kind of interesting when you have such diverse data. What worked the best were like adversarial attacks, like you have your features and you try to perturb them a little bit more during the training, so the model should be like more robust to some unique features of one cohort, which were very good. But when I did like tenfold validation, it wasn't stable across tenfold, so I give up. But I think it's like still a really open question in the field, like how you can overcome these differences in the stains. And because it's not just the stain, it's like you have different microns per pixel, you have different noise. It's sometimes even hard to pinpoint where the diversity is coming from. But yes, that's a very, very correct question. We are still working on that. So now we can, besides the performance, we can also look at this interpretability method. We can look at these attention heat maps that allows us to look which regions the model used to be most predictive for the diagnosis. Now coming back to your crash course, you can hopefully see that the features that we learned, that the model put high attention, which is shown in the red, to the tissue that is specific for each task. So in the first row is a cellular rejection, and you can see these like interstitial lymphocytes. You have this blob of lymphocytes between the tissue. In the second row is antibody-mediated rejection, where the model is putting high attention in the lymphocyte, in the edema, and so on. So you can use these like for validation. This is an interesting case. There is one patient, or here we're looking at one patient, and he has all three types of findings: the cellular rejection, antibody-mediated rejection, and Quilty lesions. And you can see the attention heat maps, and you can also see in the second column is the attention regions, the regions with the highest attentions, the ones that the model considered to be most predictive. And in the last column are the patches from the most predictive regions specified by the model. And you can see that the model is able to distinguish the Quilty lesions and the cellular rejection, and for each task is again pick the morphology specific. So in the terms of these attention heat maps, they may look like on the low magnification similar, because the model always put higher attention to the atypical tissue, but then the diagnosis is drawn from the region with the highest attention, which is then specific for each type of diagnosis. And you can also use the attention heat maps for failure cases. So here we look at the worst cases from each cohort, and they're worse in the sense that the model make wrong prediction with the highest confidence. So these are all these are all cases that the model predicted to be as a normal, but actually in the first three columns are cellular rejection, and the second are actually antibody-mediated rejection, but the model still thought they are normal. But if you look at attention heat maps, we see that the model still put high attention to the regions which contain the rejection. It just the features were not sufficient to draw the correct diagnosis, or the cutoff wasn't sufficient. But it implies that the model is like looking, it didn't fail because it was looking somewhere randomly. It's looking at the right region, just wasn't sufficient to make the diagnosis. There is, like, I keep telling you that the model pays high attention to the morphology that's specific for each disease, but so far we only saw like a qualitative assessment, and we try to also quantify like this interpretability. Also, it's tricky because these attention scores and attention heat maps, this is not a relative measure. It's not absolute measure. They just reflect relative importance of some tissue region with respect to another tissue region. Anyway, we try to like quantify this interpretability, how it is like diagnostically relevant, and we did two experiments. First was at the patch level, and the second is at the slide level. So to make this study, we randomly selected 30 whole slide images from each diagnosis, and we computed attention heat maps. And then to make like a patch level assessment, we randomly selected 3 patches which the model considered to be most predictive, and we selected 3 patches that the model considered to be non-predictive of the disease. And the 3 most predictive patches are basically defined as the patches with the highest attention score. And for the non-predictive patches, in principle, we could take the patches with the lowest attention score, but usually those contain just a very small amount of tissue and quite a lot of background. So we randomly selected 3 patches where the model attention, the normalized attention, was less than 0.5. So it's like medium to low attention, and we randomly selected 3. And then for the study, we mix these patches, and we ask pathologists to rate each patch if it's diagnostically relevant or not. And in the subplot D, you can see like AUC score that shows comparison or agreement of the pathologies and the model on diagnostic relevance of the patches. And in the subplot E, you can see like performance for each specific task. So for instance, cellular and antibody-mediated rejection, the pathologies and the model agree like over 90%. The performance is a bit lower for Quilty lesions, but this can be caused by the fact that we ask pathologists to assess patches and there may not be enough context for them to distinguish cellular and Quilty lesion. But overall, the models and pathologists agree, at least at the patch level importance. We also did like a slide level importance, and here we ask pathologists to annotate the regions that he or she considered to be most predictive for the diagnosis. And from the model, we selected regions that the model considered to be most predictive, and it's going to be the regions where the attention score is like 10 most, like 10% regions where the attention score was like the most predictive. So it's like more than 90% sure that this is like predictive. Now I want to say that the attention score, these are not segmentation of the rejection region. This is just like model impression that this region is more important than the other. So we didn't do like a dice score to compare them. Also, instead we do like a detection rate, meaning we say that the model and pathology agree if there is like overlap in the regions that they consider to be predictive. And you can see like the detection rate. And so this like study implies that the model is actually looking at the morphology that also pathologists would be looking, and at least it's like some way of quantifying it. Okay, so there are a lot of these attention heat maps, and we also make like a website where you can go and there is interactive demo and you can look at the different tissue slides and corresponding attention heat maps for different diseases. For different types of rejections and different patients. And you also see the model predictions and the confidence for each task. And we use this like interactive tool then to do some future reader study. But now if you go to the website, you can also you can also play with attention heat maps. So once you have a model, you would like to know how useful it is and how it compares with the human. I mean, the assessment of the heat maps tell us that they are looking at the similar regions, but like how well the model really performed. So we did a reader study and we recruited 5 cardiac pathologists. They all have over 10 years of experience, and we randomly selected 150 biopsies from the Turkey cohort. So it's one of these external cohorts where the model performance is actually a bit lower than on the US cohort. So we have this set of 150 biopsies and we ask pathologists to rate each of these biopsies. And we want to compare it with the model. Now, one thing to mention, it's kind of tricky to compare the model versus pathologists because in principle, each pathologist is a gold standard. And on the other hand, we know there is really large inter-rater variability. That was the whole motivation. So first, we look at a Cohen kappa, which allows to compute agreement between the model and pathology. So first we actually compute agreement between 2 pathologies. So what is subplot C is showing you, we see agreement between all pairs of pathologies. So like the first line is agreement between pathologies 1 and pathologies 2, and each color corresponds 1 task. So for instance, in blue is agreement on the rejection detection, and the straight line is the average agreement across the pathologies for each task. And we also then look at the agreement of the pathologists and the model. And for instance, we see that average agreement on the rejection detection between 2 pathologies has kappa around 0.5. So that was the blue one here. While the agreement between pathologists and model has kappa 0.63, which is like substantial agreement. So this study implied that basically the model assessment is not inferior to the pathologies, like the model and pathologists agree the same as pathologists and pathologists agree. So this was the first study, but now since we have studied...
It also means that pathologists never agree with antibodies.
Yeah, antibodies are really tricky because I didn't mention that they were discovered or agreed that they exist in 2011, so it's kind of new. And they are much rarer than cellular rejection. So there is large inter-rater variability in antibody, even more than in cellular. Yes, that's a good observation. Yes. So, but now, so we have 5 pathologies look at the same slide, so we can like compute something that we're gonna call, for the purpose of this study, grand truths, and it's computed as a consensus between these 5 pathologies. So we did one more reader study where we would like to see this is more like how the AI model can be used to reduce inter-rater variability if it's used as assisting tool. So we did this second reader study where we again recruited 5 pathologies different than before, and we used the pathologies from the first reader study and their assessment to compute the ground truths as a majority voting. So if we believe that these are the ground truth labels, we have now again set of new 5 pathologies, and we asked them in the first round. We divided the pathologies into two groups, where the first group just make the diagnosis from the whole slide images, and the second group used the whole slide images plus the assistance of the AI model in the form of these attention heat maps, exactly as the video as I was showing. So they could see the image, but they can also overlay it with the attention heat maps. And after the washout periods, the groups of pathologies switch. So those that use only whole slide images now use whole slide images and AI assistance. And what we are looking here is accuracy score and assessment time. So here each line corresponds to one pathologist. And the first column, the whole slide image only, shows the performance of the pathologist when they use only whole slide images. And the second column is when they use whole slide images and also assistance from the AI model. And we can see that, and on the y-axis is the accuracy for each task. And we can see that for all the pathologists, the accuracy increased when they use the assisting model. And also the last column showed the assessment time, so the assessment time decreased, which sort of makes sense because if you have these attention heat maps and they highlight you the predictive regions, it makes all pathologists to look at the same regions, and it allows them to, it helps them to make more correct diagnosis. And now the assumption is, since the accuracy is higher, also the agreement between the pathologies is higher. And it's like a summary of the study. So like, just to wrap it up a little bit. So the problem that we are looking at was this like an inter-rater variability. It's the high inter-rater variability in the case of assessing heart biopsies. And so I'll show you the flow of the study because I think it's useful for future studies, and it shows the direction of the work. So first we identified this problem of high inter-rater variability, then we collected data, we did the label, we developed the model. We spent a lot of time with interpretation, trying to understand if the model is looking at the correct regions, if it's like diagnostically relevant, and so on. Then we test the performance of the model on 3 different cohorts, like to assess the robustness of the model. Then we look at a comparison with the human readers. It's like, are they looking at the same regions, and how useful the model is if it's using as assisting tool for the humans. Okay, then we write a paper. And like the next direction would be to test the model on the larger clinical trials, and also like tested it inside the clinical setups, not just like in isolation, but like in the clinical workflow. In the terms of improvement, so there is this drop in performance when we go from internal cohort to external cohort, which is something we would like to investigate more. But it's still open problem, so we are looking at the different strategies, like how to overcome it. And basically, with this, I just would like to thank everyone in our lab, and here you can see the code and the repository for the demo. And if you have any questions, then now is the time.
Yeah, thank you.
Thank you.
So it was very interesting. I mean, you were saying larger cohort, but actually this is larger than other papers we used to see already.
Yes, so I think this is the largest cohort that exists in the world, and all the slides are in my office.
So you're saying you want to larger? I'm like scared. Like, is it how you're
okay, so maybe not larger, but we should more study this like diverse cohort. Like if you take data from different hospitals, different scanners, how we can generalize, like, because still we don't have all this variability, and how we can improve the generalization. So maybe not even the larger cohort, but like a more diverse cohort. That's a good point.
Yeah, and one thing I liked also is this thing, the comparison of attention from the deep learning and attention of humans. I don't know if it's the first time that someone there is all these things, explicability of AI, but I'm not sure everyone did it that formally. So no, maybe just one question that is not very related to the pipeline, but what happens if you detect that there is a rejection, how much time the patient has to have a new heart, or is it feasible?
So you don't actually get a new heart unless you're on a black market. That's a fun fact. But so you usually change the medication. Now the
And
time
they go on immunosuppressive again.
Yes, so if you depending on the type of rejection, you get different medication, and the strength of the medication also depend on the severity of the rejection. Usually the low-grade rejections are not so dramatic. Sometimes you even observe the patient a bit longer to see what happened, and really advanced rejections, those are sometimes already symptomatic, and they're kind of rare. So it's not so dramatic, but you don't want to delay it. So, but you change the medication and you observe the patient, and usually it recovers.
Okay. Other questions? So we do have people here doing digital computational pathology, so I guess they have questions.
Oh, I'm sorry. I thought you were mainly radiology, so I was thinking
No, but only two of them. Only two of them. So I guess for them they should know these things, so they might have questions. I don't know. They'll be online, and I don't know if you see Monica.
Hello.
So I don't know. You have questions or?
I was really interested in those embeddings and using the pre-trained ResNet.
Mhm.
And I'm also actually surprised that the normalization techniques and using adversarial attacks wasn't actually effective for the goal.
But it was effective, but it was never effective on both cohorts. Sometimes like really help on the Turkey cohort, but there was no improvement on the Swiss one, or the performance drop on the Swiss one. So I think the issue is that it's not just the color difference, but like everything is different. It's like different scanners, they have like a different assumptions, they do different like approximation of the data, and also like the 1 pixels have different meaning for different scanners, like we call it microns per pixels are different. So it's, yeah, we're still working on it. The issue is like usually when people write a paper, they have one external cohort, and I can like fine tune the model for that one cohort to be perfect, but this never work for two. So it's kind of tricky.
And can you hear me properly?
Yes, I'm working. This is good.
Yeah, it was very. I don't work in this thing, but it was very complex and very cool indeed. So my question is more related to if you have some sort of idea on how to generalize out of cohort, because what I was thinking is that, of course, it does not generalize correctly because it's data that it's not in your training set. So whatever, let's say, whatever distribution is fitting to the data it's simply something that it's not there. Yeah. So I was thinking that, is it possible to make some sort of a study on how this, so what is actually the model fitting into, in a way that if you put some data from an external cohort, like what is the internal representation of the network, and when you don't put this data, how is it different? So in a way, because I've seen something in the literature, it's like data augmentation, basically, that you try to some sort of generalize the internal representation of the whole data, even if it's not there. And I was wondering if actually you said that this is an open problem, but if the research is in this direction and they're trying to generalize how the network represents in whatever higher dimensional space, something that it's not. So in a way, instead of adding noise to the data itself, like some sort of add some perturbation to the internal state of the network. I believe that is some sort of dropout, but like more sophisticated. Or how is there in a way, in short, like in summary, like if the research in this, where's like how are they doing research in this area specifically, if it's done, of course.
So I like your suggestion of looking at the internal state, and so once you have the data from the external cohort, you could like do a lot of stuff. Like one direction is to train these, like I think they call it adversarial models, where you train the model to be agnostic to specifics of the data sets. So you probably saw it. So while you're training like detection of the rejections, you will also train and you force the model to learn features that doesn't allow to explain from which scanner the data came or from which hospital the data came. So you're like optimizing for your task, like you're trying to minimize the cost function to be as good as you can for predicting your task. But at the same time, you maximize the cost function for the second task, which allows you to specify where the data came from or which scanner it is. And in this way, you should force the model to learn features which are like agnostic to the specific of the external cohort. The drawback is that you need to have those external cohorts during the training, and then like different hospitals can have like different setups. Maybe one interesting thing to mention is like if you take the data from the same hospital, like the same slides, and you scan them with one scanner, and then you scan them with another scanner, and you train with one scanner, and you try to generalize to another scanner, like already for simple like cancer detection, the performance dropped by 5%. So it's like, yeah, it's the data are represented differently. So maybe what you are mentioning, like really explore the features or like very deep features under all these like differences may help, or perturbation with respect to the scanner, with respect to the staining, can help understand. But yeah, I don't have like a really generic answer for that. I wish if
you had it, we would see a paper soon enough, I guess.
exactly.
Any others or someone online? You know, Sylvia, are you there? Could be.
Yes, I am.
What? So is the other computational pathologist? Do you have questions or ideas, suggestions?
Actually, I was, because you have trained the model on only on US cohort. Have you tried any augmentation methods?
Yes, that's a good question. We try like the standard augmentation, like alternate, like adding noise, changing the colors, changing the noise, but basically the standard augmentation methods. We also try this like method, like style transfer, like we, as we saw here, that the data from Switzerland are some kind of more pinky, so we try to make the match this data from Switzerland to match the style of data from US. So visually they look very, very similar, but it wasn't very robust approach in terms of the for the model performance, or it never worked well on both cohorts and across all the tenfold validations. So none of these methods were stable enough to be like that I would feel safe to use it or claim that that's the method. The other thing maybe with the histology images, like if you do standard augmentation like rotation, it doesn't really help you. So yeah, it's maybe a little bit restricted in this way.
Okay, thank you.
You're welcome.
Okay, if there are no other questions, maybe just out of curiosity, like what do you think next steps? You will continue this, or you're the Mahmoud group are focusing on other things on pathology?
So we expand this to kidney transplant, and this is now under revision. The difference with kidney is, it's crazy difficult to assess the kidney biopsies. It's like 20 different rules, plus you use 5 other different stains. So we have to expand the model to be like a multi-stain, or like you can say multimodal, because each stain is different modality. So that's one direction. And what would make more sense is like to use like other clinical findings, like not just look at histopathology images, but also, I don't know, can we have some like non-invasive way for detecting these rejections? Because still the heart biopsy, I mean, it's very invasive, and in the case of heart is okay, but with the kidney, well, it's not okay, but it's not so dramatic. But with kidney, if you do 5 biopsies, you destroy the kidney, so you just don't want to poke to the patient, or because the kidney is really functional organ, so all the anyway, so it would be good to find correlation between some non-invasive measures like the blood values or some, I don't know, echograph or whatever, and to see how we can relate those with the morphologies that you see in the heart. and maybe search for some like non-invasive biomarkers.
Okay. Interesting.
Yeah, let's see. Thank you very much.
Anyway.